Okay, good morning, everybody. My name is Kina. I am a second-year undergraduate at UC Davis, and I am a pre-med student, and I'm currently doing genetics. So I am a volunteer at Global Offsite Care, and I'm one of the directors and coordinators for the Global Grand Rounds. So today we have our Global Offsite Medical Director here, Dr. Pekia, who will now be introducing today's lecturer, Dr. Paudel. Dr. Pekia, I'll be handing it over to you.
Thank you, Kina, and appreciate your work that you do with our volunteers at Global Offsite Care, which for many of you who are repeat attendees at this series of lectures and presentations is dedicated to providing and supporting the tools of telemedicine globally to bring healthcare to the underserved in a virtual space. So thank you again for all who are attending today, and for many I see in the audience here who are veterans of this series. And today we are honored with Dr. Prakash Paudel, a consulting pulmonologist and medical director at the Nepal National Hospital. Certified and specializing in internal medicine and pulmonology. He continues to make a significant impact in healthcare in Nepal. His educational journey includes an MBBS from Kathmandu Medical College and Teaching Hospital, and a post-graduation degree from Liaoning, if I pronounce that correctly, Medical University. Dr. Paudel is committed to improving patients' well-being through expertise and compassion. And today, he'll be speaking specifically about an evolving project known as the Global Telemedicine Center. He'll speak on a proof of concept of it and the development of what is being called the E-ICU. So Dr. Paudel, thank you so much for joining us today, and I'll hand it over to you.
Thank you so much, Dr. Pekia. So it's very nice to be here, and I have always been involved in global telemedicine since a couple of years back when we were in USA, and we were mentored by Professor Dr. Good in telemedicine. After that, all this journey began, and yeah, it's very nice to be here today. Thank you so much, and thanks to Kina, who did a good work in making all this happen. Thank you. So, good evening, everyone, and good evening and good morning to those who are in other part of the world. And so, very warm welcome to this session. Myself, Dr. Prakash Paudel, and today I'm going to present on Global Telemedicine Center, my proof of concept, future E-ICU. So this is my topic of presentation today. About me, I'm Dr. Prakash Paudel. I'm consultant physician, pulmonologist, and I'm a medical director at one of the hospital, Nepal National Hospital, which is in Kathmandu, capital city of Nepal. And we are a thriving independent healthcare provider with state-of-the-art equipment, prominent doctors and nurses. And this is a brief introduction of my hospital. So regarding telemedicine, like how it started, Global Telemedicine Center, which is located at in my premises at Nepal National Hospital, was established at the premises of our hospital on 8th November 2019 with Professor Dr. James K. Good being the valued guest from California, USA. And it was established in 2019, and in August 2020, we held a grand conference at Nepal National Hospital, and this development is always an ongoing process, and it's going now. So background of our telemedicine center is like on one fine day, 6 enthusiast doctors from 6 different institutes all over Nepal came together to do something good in the field of telemedicine. So we, including me, from different institutes, like it was from Nepal National Hospital, myself, from Shahid Gangalal National Heart Center, which is the tertiary body of heart care in Nepal. And Bhaktapur Cancer Hospital, it is the tertiary cancer center of Nepal. And Institute of Maharajganj Institute of Medicine, it is the first medical institute of Nepal. Karnali Academy of Health Sciences and Kathmandu Model Hospital. 6 doctors from these institutes came together to work on telemedicine. So with the global grant of Rotary International and support of global telemedicine, we got trained in San Francisco Bay Area. And after returning to Nepal, we decided to develop telemedicine centers in the respective institutes where we belong. And Nepal National Hospital, which is the center of all 6 institutes, which we developed as the Global Telemedicine Center. And later on, we added one extra more center, that is Muglin Highway Hospital, and along with 7 institutes involved in this development of Global Telemedicine Center. So background, Global Telemedicine Center at Nepal National Hospital has been catering for a huge number of patients from inside and outside of the valley. Valley means Kathmandu Valley. And this service has been made easier by its dedicated toll-free hotline number 1147. So we developed a toll-free number, hotline 1147, through which we receive call from different parts of Nepal, and we receive calls regarding any kind of medical emergencies, any kind of medical situations. And through this, one of the paramedical guy receives the call in this center, and he or she allocates this call or deploys this call to respected consultants of respected field. And we, these respected consultants give free consultation and free suggestions regarding his or her ailments. So during COVID-19, this hotline number was instrumental in providing patient consultation as well as treating patients through telemedicine. So this is the basic technologies used in our telemedicine room. This is a laptop, this sound device, a camera, and we have this one Kubi, which is a mini robot. We will be talking on that more on next slides. And this is our basic setup in teleconsultation room. And the main part of the telemedicine technology which we have been using here is Kubi. And what is Kubi? Kubi is a telepresence robot. Kubi enables practitioners to connect and engage with patients in many different telehealth settings, such as inpatient and outpatient visits, rural clinics, or any locations where care is being provided. So Kubi, in integration with Zoom, which is an app, provides a special in-app feature through which Kubi can be remotely accessed and controlled, which enables better interaction with patients. Kubi's pan and tilt movements personalizes telehealth for the patient and provides practitioners with the ability to engage and connect with both patient and on-site caregivers. So in this picture, we can see this Kubi camera, which is a mini robot, and this Kubi is used. It was very intensively used during COVID times by me in our ICU, in our isolation ICU, where in COVID times, we generally used to take a single round a day with all those gears, PPEs and all those gears. And rest of the time, I used to see my patients remotely through telemedicine, through Kubi, from my mobile phone, from my house, and from anywhere, from my laptop. So Kubi helped my practice a lot during COVID times, and it is wonderful. It can be used both ways, like patient to doctor as a teleconsultation, in terms of teleconsultation, as well as remotely monitoring. Like we can see in this picture also, like I can see what the patient, I can actually talk with the patient, connect with the patient, and I can even see the vitals of the patient remotely. So it helped us a lot. And along with it, tele-ICU and telesepsis, Nepal National Hospital has developed a tele-ICU system for which we have placed PTZ camera in our critical care department with central monitoring system and telepresence robot Kubi. So right now I am presenting this to you from my telemedicine center, where I am staying in my telemedicine center, and I can remotely see on all my patients from here, and I can communicate. I can monitor their patients. I can monitor their vitals, and what we are doing, we'll see gradually. So from the central monitoring station, vitals monitoring of the patient along with communication with the live feed of the patients can be done. So with this, we even wanted to see proof of concept future E-ICU. In E-ICU, we wanted to see what we can do in our local level. So in this, Nepal National Hospital, in collaboration with Global Telemedicine, have developed an intra-hospital networking system through which we could integrate monitors from different hospitals through a remote central monitoring station. 3 ICUs at different locations, that is Nepal National Hospital, Kalanki, and E-ICU Hospital, Bafal. It's a nearby hospital, and Nepal National Hospital, Nuwakot. This Nepal National Hospital Nuwakot is outside of the capital city, could be integrated through this system. And broadband internet with 10 Mbps speed is being used as the central location for real-time updates. So objective was to monitor the data from medical equipment in a centralized manner. So our objective was to, we can stay in a central station here at Nepal National Hospital, and my plan was to see and actually get the data from the monitors of remote hospital from anywhere of Nepal, and to monitor CCTV audio video in a centralized manner, and to centralize the transfer of data between separate organizational entities. So in Nepal, there is not a single medical information system in all the different hospitals. So our plan was to transfer the data from other hospital MIS to HMIS to Nepal National Hospital HMIS. So the proof of concept future E-ICU, the proof of concept was possible. It was possible. We actually did it with the locally available materials. It was not a very high-end equipments and instruments, but we could do that. And this is the first time we have done this in Nepal. So the proof of concept was at the primary location, means at Nepal National Hospital, what was required was a stable internet connection and backup connection if needed, public IP address, high-end firewall device properly configured for the scenario, and intranet, which is optional for audio, video from CCTV. And at the secondary location, that means at remote locations, stable internet connection was required, firewall device was required, and intranet, of course, it was required. So how we did it, it is a brief pictorial diagram. So what we did it was, in the picture, we can see our central CMS, central monitoring system software is right here at Nepal National Hospital. And we connected our monitors through to this central monitoring system software and our MVR system for audio visual. We connected this, and from these, we connected this to firewall device, which blocked other, which created an encrypted tunnel, and which blocked other waves, and it was single wave from our server to a remote server could be done through firewall device. So we placed a strong firewall device at our institute, and from this, the information could be transferred from Nepal National Hospital to E-ICU Hospital, Bafal, and Nepal National Hospital, Nuwakot. So in these different locations, we again put a firewall device, and through this, the band which traveled from our system was only grasped to another 2 of the hospitals, and we actually could connect monitors of monitors, CCTV, and everything from other two of the institute, and we could even monitor their vitals, blood pressure, everything by sitting remotely at Nepal National Hospital. So this is a diagram how we work, and this is what we have been doing. And with this, like our proof of concept, what we wanted to see was like, could we actually like from within the hospital, from one center to another central monitoring, through central monitoring system, it was easy and it is readily available, but connecting one hospital to other different hospital was like difficult, but we worked on it for a few months, and our proof of concept is like passed, and what we can do is we can scale up this thing, and it's scalable. So in future we endeavor to develop actual E-ICU in Nepal, which would be there is no E-ICU concept in Nepal, which would be for the first time in Nepal. This is our dream, so hope we'll reach that someday. And at Nepal National Hospital, even we are doing digital pathology for the first time. Like we, Nepal National Hospital, are using the concept of digital pathology for the first time in Nepal. Digital pathology includes acquisition, management, sharing, and interpretation of pathology information, including slides and data in digital environment. So digital pathology, we recently signed an MOU with Qiqihar Medical University, China, which is one of the largest university in China in digital pathology and telediagnostics. So it includes sharing of pathology slides from Nepal National Hospital to Qiqihar Medical University through digital scanner. So what we have, and along with it, there is telepathology rounds also we have been conducting, and it has been successful. So this is our laboratory at Nepal National Hospital, and currently we are working, like our digital scanner is on way for installation, and we hope it will finish within a week or two. It was actually donated by Qiqihar Medical University, China, and through this digital scanner, like the slides we put in this digital scanner, and we can get microscopic image from anywhere around the world. So with this, we are doing our slides, which we are getting histopathology slides. We put in this scanner, and we'll get second opinion from Qiqihar, and along with that, people having their slides and who wants to get second opinion from, let's say, from India, or let's say from USA, or from any parts of the world, they can come to our center, put their slide, and the center, whichever has this digital scanner around the world, they can get the actual microscopic image and give their opinion. So this is what we have been doing, and this is a very new thing in Nepal right now. So currently, we even collaborated with Global Offsite Care. Nepal National Hospital have collaborated with Global Offsite Care, led by Professor Dr. Good and other eminent faculties from UCSF and team of tele-intensivists to teach and train our doctors, nurses, and residents in different aspects of critical care. This includes 30-minute grand round weekly with teaching learning session from eminent faculty, and 24/7 tele-ICU emergency services provided by our tele-intensivists for management of critical patients through WhatsApp. So recently what we have started is with the leadership of our very own Professor Dr. Good, we have started a teaching session. We do a grand round depending upon the cases present at our critical care department, and we discuss the new things in that and what we can do more in these kind of patients. We have been doing grand rounds on a specific patient or a specific case basis, or sometimes eminent faculties, they give lectures on certain certain disease conditions. So this is one thing. And other thing is like 4 or 5 of the teleintensivists who are working in San Francisco Bay Area and around USA. They also are providing this service to Nepal National Hospital. Along with that, they have added us in their list, and where we can call and get some kind of information, some kind of emergency cases or discussion in emergency situation, this kind of thing, 24/7, and it's through WhatsApp. And this thing has been very wonderful. And with this emancipation, so with these things, it has been very wonderful session, very wonderful teaching learning session. And our residents, our doctors, our critical team, and myself, it has been very fruitful. And after all, we are doing this for the benefit of patients. So this has been very wonderful. And so constraints of telemedicine and future tele-ICU is like broadband internet service at remote locations. We are still working to develop a device which can actually work on all kind of monitors and even extract real-time data from the ventilator monitors. So what we did in our proof of concept session was we actually did a trial with same monitors from the same company. Like we used Mindray company monitors in all our 3 centers, through which we could generate data from remote locations. But we could not extract this from if the other remote hospitals were using other monitors rather than which we were doing the trial. So we are actually working how we can work on that. It's a basic concept, but we are working on that. And even we are trying to get the real-time data from the ventilator monitors, which we are working upon. It might need time, money, and some kind of logistic. So hope it will go, and hope we can get result with the time. And the use of different HMIS in different hospitals will be a current setbacks, as we can transfer real-time radiology and pathology data and images between 2 hospitals. Since all the different hospitals use different HMIS systems, so with this, it has not been very easy to transfer data, because from one HMIS to another, it's very difficult to transfer data. So this has been a setback in this proposed E-ICU. So activities of Global Telemedicine Center. With this, we have been doing a lot of activities. Since we are in a global network of telemedicine, we have been conducting weekly global grand rounds where we have been discussing all kind of remarkable medical cases from all around the world, followed by question and answer sessions. Every session is accredited and CME points are provided, which are funded by Global Telemedicine. I think this is the same thing which is going right now. So this kind of activities has been ongoing. And this is a brief picture where we connected Nepal National Hospital with Kathmandu with Nepal National Hospital Nuwakot. So in this, what we did was we set up a rural clinic at Nuwakot and Central. I already explained how we actually work. So this is a pictorial view, and I think we already discussed in this. So rural clinic in Nuwakot was connected with internet technologies and telemedicine equipments. The basic setup is in rural place at guidance of expert doctors in Nepal National Hospital in Kathmandu. And we have been doing training and seminars. We have conducted a lot of training sessions for paramedics and school children about telemedicine, as well as conducting different training and webinars through telemedicine. So it is very interesting to know that our 10th grad students in Nepal, they are having a chapter in their course in telemedicine. So I was like very amazed to see that, but it is nice thing which is coming up. So we have been, since we have been working a lot in telemedicine, so we even conduct this kind of short class or training in telemedicine to school students. So I was even featured in different forums, like I was featured in Rotary International Convention in 2022 as our project in telemedicine was encased as one of the most wonderful projects from Asia during that year. And even I was featured in Rotary International magazine as a telemedicine, let's say, torchbearer in Nepal or something like that, the doctor on call. And we have been doing this kind of activities. Like I was one of the faculties who regulated the telemedicine guideline in 2020-21 in Nepal. So I was in telemedicine guideline committee for the government of Nepal. So this is one of the brief video which was made by us along with global telemedicine in what we actually are doing. So I want to show one video.
In many rural parts of the world, people who are sick lack easy access to health care. Too often, their only options are to make a multi-day walk to a hospital or wait it out and hope for the best.
The lack of health care makes small problems larger, and large problems like the coronavirus pandemic a disaster.
4 out of 5 citizens live in rural areas. This means over 22 million people in Nepal struggle to get the health care they need.
Rural areas have a lack of healthcare workers and facilities, whereas urban areas are abounding with talent and healthcare workers. The solution is video conferencing. Telemedicine is the use of the internet for video conferencing for a physician to give a consultation or opinion on any patient anywhere. There are over 30,000 Rotary clubs in the world, and they are our conduit to give a proper distribution of world care via the internet. Global telemedicine enables the physician to video conference with the patient, examine the patient, and using equipment such as the electronic stethoscope or ultrasound to make a diagnosis. The diagnosis leads to proper treatment.
Global telemedicine has improved countless patient outcomes over the past 9 years. Currently, we're partnered with 18 hospitals in Africa, Asia, and the Caribbean. Dr. Prakash says when the pandemic came in 2020, it became clear that it also helps to reduce the risk to doctors and nurses. Doctors from different areas can also share what they're learning about COVID-19.
World health is being improved by telemedicine. It enables us to reach out anywhere and provide diagnostic consultation and education.
Dr. Prakash says, using the same technology, we're seeking to start a pilot project connecting hospitals across Nepal, so ICU patients from different places can be monitored from a central location.
Global telemedicine is the means of improving world health care now and in the future. I am enthusiastic this goal can be obtained.
Okay, that was the video which we made a few years back, and that is what we actually are doing. So to conclude with this, I would like to say without proper provider demand or appropriate licensure requirements, fair reimbursement and supportive regulations, the full benefit of telemedicine will struggle to be fully realized. Telemedicine should be utilized to support and strengthen existing doctor-patient relationships, not to supplement them. And global telemedicine endeavors to enhance and strengthen the quality of care provided through telemedicine. So telemedicine will help us to reach more of the people throughout the nation, throughout the globe, but it cannot supplement what direct patient-to-patient relationship would be, but it would definitely be a very important tool to reach more people and save more lives. Thank you so much.
Thank you, Dr. Paudel. Very informative and just fascinating to see how the resources that are provided by global offsite care are, making a difference out there in Nepal and elsewhere. So, specific to that, I'll start with a question, and certainly those in the audience, if you have any other questions, please submit those either through chat or simply raise your hand or get our attention. Speak directly to us, whatever works for you. But my first question is, you mentioned a toll-free hotline number that's specific to telemedicine, if I understood correctly. Is that number available to the entire population of the country? And if so, how does it work? If someone calls that number, how are they connected to care? And can you provide an example of how that might work with someone who's in a rural village far away from the hospital setting, but calls the number, is connected to a telemedicine center? How does it go from there?
Yeah, like it's a 4-digit number and it's a hotline number and it's free. Anyone call for free. And during COVID times, it was more fruitful because people were very reluctant to visit hospital or come directly to the hospitals. During the time, we got a lot of calls from throughout the country, and what we actually did was we placed one paramedics who used to receive the call, and depending upon the queries of the patient regarding whichever department, he or she would divert the call. It's not a direct diversion, but like you would get the number of the patient, and depending upon the case scenario, you would transfer this to respective. Let's say if it's regarding me, then you would transfer me this, and they would again call to the patient and would communicate, would divert me, and I would communicate with them. This way we were doing. And these times, people actually come to hospital more frequently. We have lesser number of calls, but during COVID times, we had very huge number of calls.
Great comment.
Wonderful. Great. Dr. Good.
That was a really wonderful presentation. It's nice to deal with a pioneer. The film showed an evolution of telemedicine back some years. But Dr. Prakash, you are really the best pioneer I know in the world right now in terms of telemedicine. And we're working anew on this in terms of trying to help your hospital and Nepal and other hospitals, particularly how to do it. And one way is, conferences. These conferences, the grand rounds that you're setting up very nicely on a weekly basis, that concept. But there's a new concept which we brought together, which is being able to call the consultant 24/7 using the WhatsApp. We're trying to get a way in which it'll work well. It's hard to get something like that functional because the doctors are so busy on both sides. How do you get them together on a time? And we're working on it. And my feeling is you're a real pioneer. I'm going to use that word again. And it's a pleasure working with you because you are trying anew to solve problems of not only teaching your house staff, but giving your patients better care. And I think that we are in the process of evolving techniques of doing this, particularly the WhatsApp you mentioned, and
Yep.
the problems we're having using it and so on, and how we're trying to solve those problems. But it's a pleasure to deal again with someone who's an innovator in the field. And you're doing more in Nepal as a country than any country I know in terms of telemedicine and bringing it to education and patient care. So a big thank you. And I'm pleased to work with you from my age vantage point and your youth. We'll pursue the best we can do. So thank you.
And thank you so much, Dr. Good. And it all started with you teaching us the basic concept of telemedicine, and it started, and it was way back, a few years back, and when we were there. So it started from there, and what we are doing, it's all because of you. Thank you so much.
You're teaching us now. So the shoe is shifted, which I like. Very good.
No, absolutely. Thank you, Dr. Good, for pointing that out. And as an example, a toll-free hotline number for telemedicine in the U.S. We know that there's 40 million people still in the U.S. out of 330 million that don't have connectivity. That connectivity is rapidly being provided through some resources provided by the U.S. government, and we anticipate that there will be a tsunami of demand for telemedicine, but the telemedicine pathways, the connection points in the U.S. are scattered hither and yon. They're connected to insurance companies, health systems, veterans, hospitals and clinics, and to have a singular number that anyone or any loved one of a person in need anywhere at any time to be able to connect up and obtain consistent and deliverable virtual healthcare is just absolutely a tremendous opportunity. And thanks for leading on that with your organization and Nepal as an example of how we may benefit in the U.S. A couple of questions coming in the chat. First, from the Child Life Foundation, is it a patient to provider model or provider to provider model? In other words, what type of patients are treated through telemedicine? How many per day per site? And excellent additional question to that: what is your revenue model?
Through telemedicine, basically, we have been treating more of like medicine related patients, because other surgical patients it's difficult, and even we are doing teleconsultation. Teleconsultation has been a very basic thing. As I presented, like we are working on more on tele-ICU, because me myself a critical care expert, so we are more focusing on tele-ICU things. And my current interest is more on treating patients through treating ICU patients through telemedicine, and we are working on that. And what we endeavor in future is like what we saw in California E-ICU. So my endeavor is E-ICU, through which like we can sit in a central location, and we can actually because most of the places in Nepal they are remote, and at places the availability of consultants, not even critical care, but consultants are also not even available. So in that places, like we can treat patients through telemedicine. We can actually guide the local available doctor, resident doctors, and we can do this thing. I am hoping for that. And till date, we are actually, I even discussed in conference, like we are not charging. What we are doing till date is free, and the government has currently made a guideline in revenue model. So maybe we can work, since telemedicine is still in preliminary stage in Nepal, and hope it after COVID it has evolved a lot more. So with the time, I think revenue model will be more specific, but till now we are doing this for free.
Great, thank you. Another question from, correct me if I'm wrong, Baibachan Thapa. Question is to Dr. Prakash. As you have said, telemedicine and tele-ICU came in very handy during the COVID pandemic. Can you share your experience, how the service helped you manage medical staffs in your hospital during that period?
During that period, like in COVID, we had our proof of concept E-ICU already in place in our hospital, and all my monitors and of my ICU were connected to my central station. So I could actually, and PTZ cameras were already in place in my critical care department. So I could even, the most important thing was basic vital monitoring was more important during that time, rather than going to patient and asking for history and detailed history, these kind of things, because we could not readily go to each and every patient at every time. So it was in place, and PTZ camera was in place, and all of my monitors were connected to my central monitor here in central monitoring station. So even it was in my laptop, from through my laptop, I could even see my patient's condition from my home, and my PTZ camera was connected to my mobile phone. So I think almost 70% or 80% information of my patient I could get through all these handy equipment. So I could actually tell them or guide them or actually, call them regarding any kind of vitals changes or this kind of thing. So it was handy. Thank you, Vivachan.
Great, thank you. We have a few more questions come in. This one's from Basieta Shrisa. Many patients in the rural areas are in need of telemedicine, but what can we really do to make them aware of this facility?
Yeah, in this, still the constraint of telemedicine in Nepal is in Nepal, or I would say everywhere in the world, is patients do not want to get actually treated through telemedicine. That is one of the major constraints. Rather than us giving the service, patients are also reluctant to get treated. Rather than getting treated through telemedicine, they would travel all the way long. In case of Nepal, sometimes they would walk for 6 to 8 hours to reach to health centers rather than being treated. That is one thing. So most important factor is we need to share knowledge regarding telemedicine, and this is number 1 point. Number 2 point is internet facilities is one of the main constraint in case of Nepal, because we can one-time equipment we can always take to that place or any center, but availability of internet and strong internet connection is another thing. And the most important thing is government should be aware that, okay, patient can be treated through telemedicine. Government has to be aware about this. And we have been trying to share this knowledge or deploy this kind of information to the government. As I was in policy formulation committee, we strongly recommended this thing, and government is also aware of this thing after the COVID pandemic. So this is the major thing. And along with this, we can use corporate social responsibility of big commercial institution, because everywhere government cannot reach. So big banks or let's say big companies, we have to use their 1% of their profit in corporate social responsibility, we can use this budget to incorporate one of the telemedicine center in one of the places. Like we can do these kind of things. Recently, I've been in contact with telecommunication, number one telecommunication company of Nepal, like Nepal Telecom, and which is, after I presented this thing, they were very interested in building one telemedicine center in one of the remote places rather than doing other humanitarian activities. So most important thing is knowledge, and most important thing is people have to be aware that, okay, patient can be treated through telemedicine, because in USA, like Dr. Good and other tele-intensivists, they are treating patients, ICU patients through telemedicine. And in Nepal, like we are in a preliminary stage, we are even we are in the stage of teleconsultation. So first, both ways, we have to do both of the things. Like teleconsultation has to be there, and along with that, we have to work on, let's say, teleradiology, telepathology, tele-ICU. Both ways, we have to move ahead. Thank you.
Thank you, Dr. Paudel. A couple of more questions in the 10 minutes or so we have remaining. This is also, again, from the Child Life Foundation, Sazad, thanking you for your previous answer. And additionally asking, just want to know the average cost per call and OPEX for the year, not knowing OPEX, what that refers to, but Shazad, you may want to answer that for us.
Actually,
any of that. Yeah. What is this? Expenses. There we go. And the setup costs for each of one telemedicine site.
Setup costs. Yeah, basic telemedicine, teleconsultation setup wouldn't be in that much. Like it would be around $500 to $1,000. That is fair enough. And if we scale up like tele-ICU and all these kind of things, then definitely there is no limitation. But basic things can be developed in around $500 to $1,000. It's fine.
Great, thank you. Yeah, and OPEX, thank you, Sazad, was translates to operational expense, and I think you answered that. And yeah, I think we see the theme here about the sustainability, and actually these things have a cost. They're not terribly expensive, but the churn and the burn rate, if you will, financially of sustaining these systems.
Actually.
Yeah, we always need to be aware of that. And with that, we have from Kelly Shandari, Kala Shandari. It's been a few years of the telemedicine service that you've been providing now, and it's a very progressive thinking for a country like Nepal. And I want to ask, what change have you seen so far, and how do you see yourself providing the services in coming years for the benefit of the rural community?
Yeah, I think I have myself seen a lot of changes, and with the COVID pandemic, I think this thing evolved a lot, and it transformed a lot in this last few years, because I think let's say what we had not seen in last decade, we saw in within a couple of years. With the COVID pandemic, every kind of telemedicine activities were going on, and people were aware of this kind of thing. So I think what we started, that should be a very dynamic process, like it has to grow, because during the COVID times, it was telemedicine was on the high, but it has gradually decreased its pace, but definitely it has crossed its plateau level. So I think the future is telemedicine. So for me, if you ask me, then yeah, it is going to grow rather than shrinking. So it has to, and we should continuously, as a telemedicine expert or as a telemedicine, let's say, who speaks on telemedicine, we should raise our voice for this. So I think this is going to grow bigger. And with the support of these international connections, like let's say Global Telemedicine Center has been doing a lot in developing telemedicine in Nepal as well as other parts of the world. Other bigger institutes also has to come forward to support for a country like Nepal. Definitely it will grow. I hope this. Thank you.
Great. We have time for a couple of other questions and comments. We have Prativa Subedi. Correct me if I'm wrong on that. She wanted to share a bit of her experience, and glad to hear that over the next couple of minutes and forward question you may have. So feel free to pose that. Kishore.
Thank you so much. Hello and warm greetings to everyone. I'm Dr. Prativa Subedi. I actually wanted to share the diversity of health experience that I had and which made me realize the importance of telemedicine. I graduated from Kathmandu, and as a part of my mandatory government service, I worked in Rolpa, which is one of the remote as well as war-hit districts of the country. While working there for 2 years, I realized that there were people who had to travel, 7 or 8 hours to come to the hospital. And so they could not come to seek healthcare at the initial stage and came when they landed chronically or when they had really progressed. So it was very difficult to treat them. And teleconsultations would not be possible considering their it was difficult considering their health literacy and also about the internet connections and phone connections. And then currently I'm at the United States and I'm observing in one of the university hospitals here. And I realize the difference here. The teleconsultation is as normal as an in-person visit. And I realized that the video consultations by doctor has been as effective as in-person visit, and patients, in fact, seek to get an appointment for teleconsultation rather than inpatient visits. So that made me realize that teleconsultation is as effective as in-person visit. And reflecting my experience from the past, if it would be possible to, connect, to implement teleconsultation in places and like Rolpa, that would be a great change. What I particularly realized that one of the reasons that teleconsultation is difficult in our country is because the recording system is not electronic here. It's more of the paper records. So due to poor health literacy, if we have to communicate with the patients regarding their reports, they cannot read that reports and they cannot tell the physicians about what are their findings or assessments. So if we want to strengthen teleconsultation, then I think we should, boost or encourage the government or the system here to start electronic medical records and electronic health records in the country. And since I personally feel that now I'm at the privilege to be in a country which is, although my visit is short, which is technologically so advanced, if there is something I could do while I'm here that could benefit for the coordination of teleconsultation in my country, I would be really happy.
Right. Thank you for that. That's an important point about infrastructure and platforms. When we have the opportunity to provide care like this, definitely need to have a singular platform whenever possible to share that information and archive it. And with that, we've run out of time. Wanted to have a minute to thank everyone. By the way, if you have the additional questions that you have, we'll go ahead and pose those to Dr. Paudel and get back to you. I believe we can do that through the email addresses that we have. So thank you for those additional questions, and we'd be happy to share the answers to those with the group. So want to recognize a few people in the session today who represent, in particular, Dr. Good, representing Offsite Care, Inc., and his medical group that he founded over a decade ago, dedicated to tele-intensive care and telehospital care, and was part of the group from the Sebastopol Rotary International Club in Northern California that started the 501c3 that we know today, Global Offsite Care. And again, thank you to those Rotarians, Dr. Good, and our other supporters, both with Rotary International and individual supporters over the years of Global Offsite Care. We're past the 10-year mark at this point. And also for those who attended today and also interacted with us. So with that, we will close and hope to see you all next month. Back to you, Kina.
Thank you, Dr. P, and thank you so much, Dr. Paudel, for your insightful presentation. And as we come close to the end of our presentation and our time here, I'm posting a couple of links in the chat, and if you're interested in presenting in the future, feel free to reach out. And our next Global Grand Rounds is on October 11th, and it will be the same process as this, and everyone's invited. And if you are interested in presenting, feel free to reach out. And as always, we appreciate your participation and continued interest in Global Offsite Care and the Global Grand Rounds. Have a great day and then have a great night. We hope to see you again.
Thank
Thank
you.
you so much.
Bye. Thank you.